Good evening, everyone. I am Dr. Susan. I'm a consultant in liver transplant anesthesia and intensive care. So today I'm going to talk about liver function tests and the interpretation of liver function tests. So this, I would say, liver function test and their interpretation is an important topic, not just from an anesthesiologist perspective, but especially for the for an intensivist or physicians involved directly with managing liver patients or in the emergency department. So first, let me give you a rough introduction about liver function tests. So these are also known as liver biochemical tests, and they specifically help in diagnosing the presence and the pattern of a hepatic dysfunction so that you can yeah. So this can help in diagnosing the presence and the pattern of hepatic dysfunction so that further direction can go for the appropriate diagnostic evaluation, and also in assessing the severity of the disease, and also to assess the response to a specific treatment. So it can act as a screening modality, as a tool to identify the pattern of the disease and assess the severity of the disease and the response to a treatment provided. So what are the components of liver function tests? So here I have listed a number of tests which will come when you order or when you ask for a liver function test for any patients. So first and foremost will be a total bilirubin. So total bilirubin will be measured in milligrams per deciliter. This will be followed by direct and indirect bilirubin methods. Indirect bilirubin. So the test that is used here will be a diazo test, which first measures the direct bilirubin, and then they will add an agent to the testing medium, and then the total bilirubin will be obtained. So the indirect bilirubin is usually a calculated value. So what we usually get is a direct bilirubin, and then you have your total bilirubin. So direct bilirubin measures the conjugated conjugated bilirubin levels, while your indirect measures your unconjugated bilirubin levels. So this is followed by the liver enzymes. So we have the aspartate aminotransferases, alanine aminotransferase, alkaline phosphatase, gamma glutamyl transpeptidase, 5-nucleotidase, and lactate dehydrogenase. So these are some of the important enzymes, liver enzymes, which can help us in diagnosing or demonstrating hepatocellular injury and bile duct injury. So I have listed the units and the normal reference ranges. You can go through this later at a later point, which is not required at the moment. So then you have towards the end of this list, we have the total proteins, which will be your albumin and the globulin levels. So albumin will be measured separately, and globulin, and then we have the ratio, the albumin and the globulin ratio, which is usually more than 1, indicating that albumin will be more than the globulin. So a quick revision of the functions of the liver. I have discussed about this in detail in my other classes. So here I will just highlight what things that we need to look for when you're going to assess for hepatocellular and cholestatic injury. So the function of the liver is in multifactorial. Many modalities. So you have some storage functions. There are some degradation functions, some metabolism functions, and some related to synthetic activities. So storage, what you mainly look at is your glucose and the vitamins and iron and also copper. While degradation, it is involved in breaking down of insulin, bilirubin, ammonia, and some drugs. Metabolism, again, it is involved in carbohydrate and lipid metabolism, while the synthetic function includes many proteins, especially the albumin, coagulation proteins, CRPs, and some hormones, and so on. So first, looking at bilirubin. So bilirubin is usually produced as an end product of heme metabolism, which is derived 80% from hemoglobin and also from myoglobin. So this is produced as a water insoluble component, and it cannot be excreted directly in urine. Hence, it requires a process called conjugation. So this indirect bilirubin, as I mentioned earlier, measures the unconjugated bilirubin component, which is not soluble in water and it cannot be excreted in urine. While the direct bilirubin measures the mono on the diglucuronide conjugated portion, which will be water soluble and it can be picked up in urine. So the total bilirubin is a sum of the both. So a quick revision again of the bilirubin metabolism, where you have the breaking down of the RBCs, release of heme, and the production of the unconjugated bilirubin. So this then gets attached to albumin and it is carried in the bloodstream to the liver. While it is in the bloodstream, it forms this complex, the unconjugated bilirubin albumin complex, which is picked up in your indirect bilirubin test. So then it goes into the liver where the enzyme action happens, the conjugation process happens, and then you have conjugated bilirubin, which is then is then excreted in the bile, and it moves on into the intestine where the gut bacteria acts on it and it produces urobilinogen. So some of this goes into the feces and it is excreted as stercobilin. 2% of it goes into the urine as urobilin, while 18% goes into the enterohepatic circulation and it is again carried back into the liver for further metabolism. So this is the metabolism of bilirubin. Now let's look at the places where there can be a problem with this metabolism. So first and foremost is your bilirubin overproduction. So what are the situations where the bilirubin can be produced in excess? So this will be hemolysis or polycythemia, where you have a lot of RBCs, and in hemolysis you have a lot of RBC breakdown, resulting in increase in the amount of heme production. So again, so this will result in unconjugated hyperbilirubinemia. Then you have impaired uptake. So this happens when there is an intestinal obstruction, or in cases of sepsis where there is hypoperfusion, or in case of a congestive heart failure. Again, you will have unconjugated hyperbilirubinemia. So what about metabolic disorders where the conjugation process itself is impaired because of enzyme dysfunction or non-production? So a few metabolic disorders like Crigler-Najjar syndrome, Gilbert syndrome can cause unconjugated hyperbilirubinemia. Then comes the situations where there is hepatocellular injury due to infections, metabolic disorders, toxins, immunological disorders, which can cause damage to the hepatocytes, and this can result in a mixed picture. I can be either both unconjugated and conjugated, or a conjugated hyperbilirubinemia alone. And then comes the situation where there is an extrahepatic obstruction resulting in decrease or no outflow of the bile. So this situation would be like biliary atresia, choledochal cyst, cholelithiasis, primary sclerosing cholangitis, and primary biliary cirrhosis. So this can lead to conjugated hyperbilirubinemia. So this again is a representation of the stepwise problems that we can face in the metabolism, resulting in the specific hyperbilirubinemia. So again, I'm not going to go through it because we have just now discussed about it, but this is a good picture to remember the causes and the problems associated with this bilirubin metabolism. So now when you say jaundice, when a patient comes to you with jaundice, the first thing that you need to know is what is the type of jaundice. Is it a pre-hepatic, a hepatic, or a post-hepatic? So then these tests will help you to identify what type of jaundice it is. So as I told you earlier, total bilirubin is a combination of both. So it's just going to tell you that there is a rise in the bilirubin. Then looking at your direct and the indirect bilirubin levels, you will get a better picture. So in the pre-hepatic jaundice, your conjugated bilirubin will be normal, whereas it will be increased in hepatic and post-hepatic. In unconjugated, while your unconjugated bilirubin is raised, it will be prehepatic most commonly, and also in hepatic jaundice. However, in post-hepatic jaundice, the indirect bilirubinemia, bilirubin levels will be normal. Then you look at the urobilinogen levels. This will be increased in prehepatic or normal, whereas in hepatic it will be increased. In post-hepatic it will be decreased. Urine color, again, a dark urine color will be seen in hepatic and post-hepatic because of the presence of urobilinogen and conjugated bilirubin in urine. And stool color will be pale in post-hepatic jaundice, and it might be pale or normal in hepatic, whereas in prehepatic it will be normal in color. Then comes your enzymes, which will help us in further diagnosis. I will discuss about it in the next slides.